Well, and a very happy good evening to all. It is time once again for Fertility with Fink and Friends. My name is Dr. Randy Fink, and I'm a fertility gynecologist here at New Life Fertility in Pensacola, Florida. We also have offices in Mobile, Alabama, and Pensacola Beach, or I'm sorry, in Panama City. I also work with the fine folks at the Missouri Center for Reproductive Medicine, MCRM, in St. Louis. And in Tulsa, it is 5 o'clock on the Gulf Coast, which means 6 o'clock in the east, 4 o'clock in the mountains, and 3 on the west. Fertility with Fink and Friends is the place you are supposed to be every single Tuesday evening at this time. And it's great to see you. I hope your week has thus far been wonderful, that your weekend was great. We've got thunderstorms here on the Gulf Coast right now with a hearty, actually it's 84 degrees. It was 92 degrees when I looked about 15 minutes ago. So I guess the storms may have probably cooled it off just a little bit. So not such a bad thing. Heat waves are out there. Everybody is trying to stay cool. And I did actually have a great question. And the question was, does the heat keep me from getting pregnant? Does it have anything to do with my fertility? And the answer to that is nope, it really shouldn't. It should not have any effect on things like egg quality or an embryo transfer, on the function of sperm. Now, that said, sperm are supposed to keep themselves cool. So guys who are spending a lot of time, in hot tubs and things like that, well, that actually can have an effect on sperm. But as far as the heat, the humidity, dealing with the heat wave out there, not something that should be a problem for you, but a very good question. So let's say hello to Nurtured Shanna. Thank you, Shanna, for being my number one here tonight. It's great to see you as always. As number two, a close, not far behind, is the lovely Bama gal and husband, and that is my mother, Miss Emily, and Mr. Harold, sitting in Mobile, Alabama this evening and watching my show. Thank you very much for watching. We've got Lauren, who has joined us over here on the New Life Instagram side. So we've got a couple of different feeds here. We've got New Life Fertility's Instagram right here. We've got my Instagram, that's Randy Fink MD. We've got Facebook, a couple of different Facebooks for New Life and for MCRM. We've got LinkedIn, we've got YouTube, we've got First Fertility, because we are proud to be a part of the First Fertility Network. So I am Fink and you are friends, and tonight we are here for you. So throw your questions my way and let's see what we can do to try to help you out. Shanna asks, a nutritionist suggested adding 5 MTHF, 5 milligrams, and a gallbladder supplement due to possible absorption concerns. Any thoughts on adding that during an FET cycle? Well, so basically what you are, and no hand, foot, and mouth signs or symptoms from you yet. I'm glad to hear that. That's very important. So methylated folate is probably not an unreasonable thing for really for anybody. And basically what methylated folate is that it's a type of folic acid that may be more easily absorbed by your system. As it turns out, probably about 40 to 50% of us carry a gene mutation that's known as MTHFR, and that's methylene tetrahydrofolate reductase, is the name of an enzyme that prevents us from correctly absorbing folic acid. Now, in most cases, it's really not all that significant. And we used to think that that was a big cause of things like recurrent pregnancy loss. And now we know that it really is nothing to do with it. So again, fully probably half the population is positive for MTHFR. But if we knew that you were positive for MTHFR, then we would say use the methylated folate, which is called methylated folate. So that's what I think you're referring to there. So Shanna, yeah, I see there is no downside to using it, because if you absorb regular folate correctly, then you're still going to absorb that. And if you don't absorb regular folate correctly, you still probably absorb enough folic acid that it's not really a problem, but you will absorb that folate better. So yes, my preference is for methylated folate in any type of prenatal vitamin. So as far as gallbladder supplements, so that's a little bit more of an esoteric kind of thing, because is there really such a thing as a gallbladder supplement? Is there a supplement that truly helps the function of the gallbladder, that is secretion of bile, in order to help you digest fats? And the answer to that is, well, there may be, but I have never seen any good evidence-based supplement that specifically helps the gallbladder, nor do I know why gallbladder would be something that you would need to help as it pertains to FET. But if it has nothing to do with your embryo transfer, is it harmful to start it now? The answer is no. I think you certainly can. I think that's fine. And if the nutritionist believes that that's something that will help you, I will certainly defer to the nutritionist's expertise on that, because I was going to say, I am not sure so much about that one. But yeah, it's okay to take, and I do think that methylated folate is probably not a bad idea. Hi to Nick PD, and hello to Pui in St. Louis, my favorite sushi restaurant owner. I'm going to be there in July, and I can't wait to come see you. Over here on the New Life side, a special hello to Angela. Angela, it's great to see you here tonight. As always, you are always a breath of fresh air for us here. I see there's a few people over on the Facebook and the YouTube side, but I can't see who you are, so feel free to shout out and say hello. Well, gosh, what else do we have going on here? I was asked a question about something that we see really very frequently, and it has to do with men, and it has to do with men on testosterone. And the question was, once you've started testosterone, can you make your sperm count come back? And the answer is, in most cases, yes. So I'm fond of saying that we as men, oh, by the way, if you didn't notice, I'm in a little different setting here tonight than sitting in front of the brick wall, because this is in my regular office. This is my regular office chair. And so I thought I would just try a little different scenery here tonight to see if we couldn't shake things up a little bit, make things look a little bit different. And hopefully that's meaningful to you, because it's meaningful to me, and that counts. All right. So the question again was about sperm and testosterone. I am fond of saying that we as men are fundamentally lazy down to the cellular level. And so if those cells that make testosterone in our bodies see that we are getting testosterone from another source, like you're getting a testosterone injection or a cream or a pellet, if you're getting testosterone from the outside, those cells that make our testosterone on the inside will say, well, dude, it's coming from someplace else. We don't have to do this. I'm taking a nap. And so they stop producing their own testosterone. And those cells that make that testosterone are also the cells that make sperm. So you stop making testosterone and you stop making sperm. And that is a problem when you're trying to get pregnant. So the testosterone may do all kinds of things for libido. It may help your sex drive, but it is a fantastic form of male contraception, because it will drive the sperm count down to nothing. And then when you stop using the testosterone, you're not making testosterone of your own. And at some point you might start to get a little bit more, but in general, your number is going to be very low. So if you are using testosterone, what we know now is that you don't actually have to stop it. There is medication that we can use that will, hi Ruby, that will make you return to generating sperm. The problem with that is that it takes 3 months. The sperm that comes out today was manufactured in the male body about 3 months ago. So it takes a little while. It's some injections. It does not mean that you have to stop using your testosterone. In fact, the current data shows us that the old mantra that the testosterone has to stop is no longer valid, that it doesn't meaningfully change the production of sperm. So you can stay on your testosterone, you just have to keep using the medication. Now, what happens to that count? In most cases, the count will become adequate for you to be able to do IVF. And that is to say, oh yeah, that's right. And that is to say that, okay, I got to just take a quick aside here because my daughter Ruby is saying, oh my God, that's my art in the back. And yes, see that thing right there? Oh, actually, if you're here, that thing right there, Ruby made that and it won a big prize in the art show. So yeah, Ruby is quite the artist and she'll paint your dog for you too. $100 worth every penny of it. Anyway, so thank you for pointing that out, Ruby. Yes, it's your artwork. Where was I saying? It's kind of strange to be talking to my daughter and then to return to talking about sperm, but she's used to that in our house, you know. Oh my gosh, we also have Max joining us from Colorado, who is another of my offspring, my oldest son in school in Fort Collins. Good evening, Max. It's great to see you. Gosh, it's like a whole family reunion thing happening here tonight. See what happens when I don't sit in front of the brick wall when I'm at my regular desk. I get all kinds of special visitors here. In any event, if you start using the medication to make that sperm again, you may not make enough sperm that it's going to be sufficient for a spontaneous, normal kind of conception. It will almost always be adequate for IVF because even if you make 1 million or 2 million or 3 million sperm, we only need 1 sperm for each egg when we're doing IVF. To meaningfully be able to do something like an insemination or IUI, that takes about 10 million sperm. And for spontaneous conception, it means really consistently 20 million sperm every time. And when you're using that expensive medicine and it's an ongoing process, that becomes sometimes a real challenge. So what many guys do is that they will do that first specimen and they will save it. They will save that sperm, will cryopreserve that sperm so that it's there for use. And then you can stop using all that other medication and go back to just using your testosterone and feeling good. And then we can use that cryoed sperm. Hello, Sharmila. Nice to see you here this evening. Oh, and my gosh, Kaylin is with us from the panhandle of Texas. And I feel really, truly honored to have all these special people. You know, I'm going to have to start doing this podcast from not in front of that brick wall anymore, because look at all the people who are joining me here tonight. But so that, I hope, answers your question about testosterone and sperm, because, yep, that testosterone will drive that sperm down to nothing. But yes, we can make it come back. We just may not be able to make it come back in the normal type of production, in the normal volumes that are required. Some of that really just depends on how long you've been on that testosterone. So let's see what else we got going on here. I had a question about how do I know how many eggs I will be able to retrieve in my IVF cycle? And the answer to that is, well, you never really know. But a good way to estimate the two things that we typically look at, we look at one, the hormone level that's called your AMH, your anti-Mullerian hormone. The AMH is a general reflection. It's a proxy measurement of how many eggs you got in your body, because every one of those little eggs, and by the way, eggs, you know, the sperm that comes out today was manufactured in the male body 3 months ago, but every egg that you will ever have in the female side is there on the day that you're born. So over the course of our lives, we start to lose these eggs to the process of aging. The DNA in those eggs starts to become less stable as well. And so we can't actually count the number of eggs because they're microscopic and there's millions of them there. But every little egg is surrounded by some cells. And these cells make a hormone that's called AMH. So the more eggs you have, the more cells you have. And the more of these cells you have, the more anti-Mullerian hormone you will make. So we can measure that amount of hormone in your blood and use that as kind of a proxy measurement of how many eggs you have left. We can compare you to other people who are your age. And you can simply look on the internet, Google AMH level by age, and you'll see a nice graph that shows you kind of where the 50th percentile, where the average level should be there. And that kind of tells us one thing. The second way we know is by looking at something that's called the antral follicle count, or the AFC. And what does that mean? It means in the beginning of the menstrual cycle, your brain tells your ovary, give me some eggs. And the ovary says, okay, I can do that. So it dips down into its well and it pulls up a ladle full of little egg houses. And these egg houses we call follicles. A follicle is quite literally a little sac of fluid with a microscopic egg in it. So we can look at your ovaries in the beginning of the cycle and count up the number of follicles we see there, because that would say it's a rough approximation for how many eggs could we retrieve from your ovary during that cycle. So in theory, if you have an AFC, an antral follicle count of 10, then I would say, well, approximately 8 to 12 would be the kind of number of eggs that I would think we're probably going to be able to get from your ovaries. Now, the AMH level does have something to do with that, because the higher the AMH means that the greater and the more easily your ovaries will respond to the stimulation medication. The lower that number means the more we're going to have to work to try to get your ovaries to respond. And that's an important consideration, because that's how we can really make an educated guess about how you're going to do in any one cycle of IVF. But to answer the question, can we estimate how many eggs? Oh, see, Kaylin, you made me yawn. The way that we can estimate the number of eggs is really by looking at the antral follicle count and sort of weighing that also against that AMH level. So we also have Zemanarahima, I think, if I'm trying to say it fast there, who has a question for us, and we will answer that in a moment. Hi, Erica Alyssa. M. Wonderland, good evening, as well as Sarah Davis. Hello. And let's see, Z asks me, does Omnitrope add any value to a low AMH? So if your AMH is low, that is what we call diminished ovarian reserve. Does adding growth hormone help in the case of a diminished ovarian reserve? Well, the truth there is, Z, we can't give you any more eggs than you already have in your ovaries. So those eggs are there. They're there from the day you're born. You're not going to have any more over the course of your life. And if we looked at that graph, we would see that progressively, pretty steadily, in a linear fashion, we start to lose those eggs. So a low AMH means that you have a lower than expected egg count. Where Omnitrope may come into use, and Omnitrope, by the way, is human growth hormone. And so the issue there is not going to be so much the quantity of eggs, but rather the quality of the eggs. So as we mature, our growth hormone levels will start to diminish. They start to drop. And so that's why folks will use growth hormone in the anti-aging side of things. People will use it for the long haul People who are involved in weightlifting, bodybuilding often use growth hormone as well. So the thinking is if we are losing our growth hormone, maybe that is something that contributes to aging. And aging is a concern as it pertains to those eggs. So thinking, well, gosh, if you have a diminished ovarian reserve, then it may be because you're a little bit older, and because, and not always. Sometimes people with diminished ovarian reserve can be very young, which is why I always encourage people to find out, to know what your AMH level is. I think that's really important. If you don't know it, go get it tested. Ask your doctor. Even if you can ask your gynecologist, they'll know what that is. Your family doc may not really know, or primary care won't necessarily know what an AMH is, but you can ask them for it. You can explain that's a marker of my ovarian reserve. I don't expect for you to interpret it. I just want to know the number. And then you can interpret it yourself by looking at the graph. And that maybe will tell you, how loud is the clock actually ticking? You know what I mean? So I do think that that's important. But getting back to your question, Z, I'm sorry I got a little sidetracked there. Using some growth hormone is said to be helpful for egg quality, even though the studies have not demonstrated that omnitrope is necessarily helpful to people, that it doesn't do much other than increasing the cost of IVF. And it is an expensive medication. If you've used it, you know omnitrope is not cheap. So if the data says, well, wait a minute, but it's not helpful, then why do so many practices, grab for it? Why is that something that you're using when we're doing IVF? It is the kind of thing that we reach for. It's been around for a while, and it just seems like a good idea. All of us have seen scenarios where folks do IVF and then they do another cycle using omnitrope, and their outcomes are significantly better. And so it begs the question, well, all right, is that just because it is what it is? It was luck because it's another cycle, or why is that? Is it because of the omnitrope? I think that omnitrope or growth hormone probably does help some people. The problem is we just don't know exactly who those people are. We don't know the precise cohort, the precise chemistry in your body that means that growth hormone is going to be useful in your case. And so therefore we kind of reach for it for everybody as one of those things that is designed to improve egg quality. And sometimes, Z, it certainly does. Now, another thing that may help with egg quality is a medication that's called sirolimus, also known as rapamycin. This is something that we are experimenting with more. We're using it more and more now. And there's some pretty good evidence that, and it's, dirt cheap, that it may actually really help with egg quality too. So hopefully that helps you, Z. And I'm so sorry that I have a hard time pronouncing your name. Maybe one day I'm going to sit down and look at it and figure out how to pronounce it correctly, or just help me to answer that back. What is the correct pronunciation of that screen name? A special shout out to Angelina Foxy joining this evening from Minnesota, where it's probably snowing while it's thunderstormy and 90 degrees here on the Gulf Coast. But Indepino Journey, good evening to you, as well as my friend Jazzy Poo. Nice to see you guys on my Instagram here. That's Randy Fink MD. We've got Facebook, LinkedIn, YouTube, all kinds of things over here. Michelle is here, who says, love the information. And Michelle comes from the Facebook side. Thank you for speaking up there, Michelle, because I can see people are watching. I just can't tell who it is. And over here is my friend Shada on the New Life Fertility side. And I know that Shada had a big surgery just the other day. And I hope you don't mind me sharing this, It was thought to be going to be a nice, easy surgery, but when they got in there to look for endometriosis, I guess they found an awful lot of endometriosis. So it sort of turned into a big surprise there. It took a lot longer, I think, than expected, but we're so glad that you came out the other side of that, Shada, and hopefully you are recovering well. Shada asks, after a major endo and adenomyosis surgery, is 3 months enough for the uterus and the body to heal before doing an FET, or do you need to wait for more time? I would think in most cases, 3 months should be very adequate. Now, here's what happens sometimes. Sometimes the inflammation, depending on what they did in the surgery, the inflammation as a result of that surgery can end up leading to some signs of very obvious inflammation in the pelvis, like some collections of fluid and things like that. And so if it turns out that as you're getting geared up to do your next transfer, the ultrasound suggests that you've got an inflammatory process going in still post-operatively in your pelvis, then in that scenario, I would say you might hold off a little bit. However, 3 months really should be plenty adequate. And the follow-up question there was, what things should one do while waiting? I'm on Lupron for 3 months, along with 5 milligrams of letrozole. Any other testing or anything else I should do while waiting to do my embryo transfer? And the answer is nope. I think you got this covered. So as you know, Lupron is a drug that will suppress your hormones and thus turn off the food supply, as it were, to endometriosis. We know that when you have endometriosis, they say that either suppression with medication or surgery should be equivalent in improving pregnancy outcomes. Now, if you do both, that's fine, and it looks like, I think, that's what Shada has done here. The additional thing that you've done there, Shada, because you had the surgery and because you had that endometriosis removed, what we do know, and you may have heard me say this before, but the endometriosis that we see is really just the tip of the iceberg. There is always more endo than what meets the eye. And so by doing medication afterwards, you're really probably fully taking care of the entire bulk of endometriosis that you have. So I think that was a very smart move on your part. And you're even going double the mileage there because you're using both Lupron and letrozole. So why would you do that? Lupron is pulling the plug on hormones, right? It's going to put you into a temporary menopause, which doesn't sound very pleasant. And it's not, but it's not the end of the world. It's not terrible. We can do things to treat symptoms if you get things like hot flashes and so forth. But Lupron is turning off the hormones from the level of basically from the pituitary gland in the brain. Letrozole, when you take it with it, is taking what we call the peripheral conversion of estrogen. And that is the estrogen that gets made in our fat cells. And I don't mean that pejoratively or punitively towards anyone, because we all have fat cells. Some of us have a lot of them, between these two structures. But we are always taking our testosterone, and testosterone will become either the active form of testosterone or it becomes estrogen. So estrogen is made in the fat cells. What does letrozole do? Letrozole stops people from making the estrogen. So you're really shutting off the entire food supply to that endometriosis, which really, I think, will make a big difference in your life in terms of how you feel on the inside. And God willing, it has been long enough, my friend. I think I am ready for you to get pregnant. And if I'm ready for you to get pregnant, that can only mean one thing, that you are more than ready to get pregnant. Don't you think? I think so there. And a special shout out here this evening to Tracy in South Florida. Good evening, Tracy and Katz. and cats and kids, in fact. Hello to all, and dogs, cats, kids, lizards, all the other things that live in your home and share under your roof with you. And yes, the lizards, they definitely do. But at least you don't have frogs in your bed and that sort of thing. Or I don't know, actually, you might. You should check, actually. Tonight, when you're sleeping, as you're dozing off to sleep, you might just check and make sure that there are no frogs or lizards in the bed with you. I'm just saying. I'm just saying. Oh, gosh, look what time it is. It's 1/2 past, which means on Fink and Friends, it is time we do something that's very important, and that is called the 5:30 Fuzzies with Fink. And what is that all about? That is all about this. Hope is something that becomes hard to come by as you're dealing with problems in the world of fertility. And if you've been there, you understand. And even if you haven't been there, you understand, because life is not easy for us. Life throws its curveballs every time we look up. It's hard to know who's out to get you. It's hard to know what's going to happen tomorrow. It's hard to know, is this going to work out for me the way I want it to? All these things just raise questions in our minds, and those questions create anxiety, and that anxiety makes us really quite uncomfortable. It makes us feel lonely. It makes us feel afraid. Whether it is about fertility for you, or about the workplace, or about friends or loved ones, relationships or family, no matter where you go, you are not alone. The 5:30 Fuzzies with Fink is the time for us to all stand together as one community and really send out the best wishes, the best vibes, all that positive energy we can muster up to everybody out there tonight who needs to know that they are not alone. It's a lonely place, but there's no reason to feel alone. Everybody who watches this broadcast, I always say, I really feel, honestly, as someone who would, in a heartbeat, give the shirt off their back to somebody else who was in need. So let us all break the internet with kindness if we can. Do something nice tomorrow. I always advocate this. Smile at a stranger. Just random acts of kindness go so far in this world and really help to give both the giver and the recipient the hope that tomorrow brings a new day. And it really does. And that, my friends, is the 5:30 Fuzzies with Fink. So thank you for participating. Thank you for sending out your positive vibes tonight to all those out there who need it. And that said, Z asks me, is there hope for someone with an AMH of less than 0.08? Well, that's kind of the number that we use to say that the AMH level is now undetectable. And when the AMH is undetectable, it's suggesting to us that the egg supply in the ovary has really probably been used, that there probably is not going to be a meaningful response to medication in order to get you to produce eggs. So it certainly doesn't mean that there is no hope for someone, because there's always hope, but there may be a different answer. And it may be that IVF for you, or doing a fertility treatment using your own eggs, is not going to be the most efficient choice. I think it's worthy of a conversation. While there is always hope, I want people to have realistic expectations about the sort of things they can expect with treatments. Now, Z, I will tell you that your uterus does not age at the same rate that the ovaries do, and that the ovaries may think that they're 5 years older than what you are, but your uterus probably still thinks that you're 25. So that really is a good thing. That means that there is something that we can do. We can make something work. But yep, it takes an important conversation to really understand truly what that means. Hi to Katie, and looks like Aub Fraley. My friend, the cowgirl, says baby dusts and positive vibes to all. I have a story to tell you about this cowgirl person. When I first got to Colorado, when I first moved to Colorado, so I had been in South Florida for, oh gosh, practicing for 21 years before I moved to Colorado and started there. This cowgirl, who is no longer there, was working at that place, and I will say she is the first person. And I don't get me wrong, this cowgirl is a very, very special person, but she is the first person ever in the state of Colorado to tell me to shut the F up. Yeah, she did. And she really didn't know me. She just knew me as the doctor who worked in that place. And so it was a bold move. I give you that. I'm the very first person in Colorado to say, shut the F up. And so she will always be a memorable person in my world. You got it. Yeah, baby dust and positive vibes to you, cowgirl. Let's see. We got Danielle here with us tonight, as well as Kate Balky. Nice to see you. Indipino Journey, my friend, has a question. I tested negative for BCL6, which is the marker for endometriosis, and I tested positive in 2025. Why is that? And is that test accurate? Well, to the extent, so let's talk first of all about what that test actually is. The test for the marker of BCL6 is a test that's called Receptiva, and they are the only people, it's a proprietary marker. They are the only people who can run that test, so you only have one choice to get it done. It's called Cicero Diagnostics, and their website is receptivadx.com. So classically, the diagnosis of endometriosis could really only be made by surgery. When we became able to diagnose it non-invasively, this was a major step forward, particularly for those in the fertility world. And the marker was really developed to understand why some people would have recurrent embryos placed inside the uterus, but they weren't getting pregnant. And what we learned is that endometriosis, can do a bunch of different things to you. It can cause scarring on the inside. It can change the anatomy. It can create a pain syndrome. But from a fertility standpoint, it can lower your ovarian reserve. It absolutely does that. But the other thing it does here is that it can mess with the way an embryo implants inside the uterus in the endometrium by opposing the most important hormone you have for pregnancy, and that is progesterone. Progesterone, that's the hormone that maintains the pregnancy in the beginning of the pregnancy. And so what we can do now is that we can do a test for that marker, BCL6, by placing a little straw inside the uterine cavity and sucking out a little piece of tissue that they're then able to test for the presence of this BCL6 marker. And if it's there, it means there is a very significant difference in your ability to implant a pregnancy, like a very significant difference, unless we suppress that endometriosis. That is to say, we treat you with the medicine like Lupron and Letrozole, or a medicine like Orilissa, which is a pill that you can take, in order to shut down the food supply to that endometriosis. And that is said to negate that BCL6 marker in the uterine lining. So why would it have been negative in 2022 but positive in 2025? Well, endometriosis is not something that you are necessarily born with. Now, there are some people who present with endometriosis as soon as they are in puberty. It can start very, very early, but we don't believe it's something that you are born with, rather something that you may acquire later on in life as you start menstruating. So it may have been negative a couple of years ago, and then it grew to the point where now it's positive and it's expressing in the uterine lining. The other possibility there is that while you could have had endometriosis before, we think that most, if not all, of endometriosis, certainly most endometriosis, will express in the uterine lining, but probably not all. Most, but not all. So there are some people who have very classic symptoms of endometriosis. But then when we test in the uterine lining, it's negative. And I would have to say that's probably because there is a cohort of people who aren't expressing it in the endometrium. However, most people with endometriosis will have that marker. At least that's what we believe. So it actually is a very good test. It's said to have up to 96% specificity. It's not 100%, but for that matter, neither is laparoscopy. We could do a surgery to take a look inside of you and come to find, oh, it doesn't look like there's any endometriosis here, when in fact, again, there's more to it than what meets the eye. So I think you probably acquired it, or it wasn't affecting the endometrium, and now it is. But the important thing to know is that it is. Because when I said that it has a significant effect on your ability to implant a pregnancy, let's talk about what those numbers mean. So let's say that you have an embryo, and that embryo is a euploid tested chromosomally normal embryo. That embryo, in theory, should get you a 65% probability of a pregnancy. If you are expressing that BCL6 marker, then that 65% number drops down to about 8%, certainly less than 10%. That is a big difference. If you suppress that endometriosis for 60 days, the evidence shows us that your 8% number goes all the way back up to 65%. And in fact, I've recently seen some data that says that in some cases it may even be higher than 65%. It may be, even close to 70% probability of pregnancy. So identifying that BCL6, I think, is important, and treating it or suppressing it is also really critical as it pertains to those who have tried to place embryos but aren't getting pregnant. Now, is it an appropriate test for people who just want to know if they have endometriosis? Well, really the truth is, in general, it has not been validated as a test for the general public. So if you say, gosh, I've got painful periods, I think I'd rather have that Receptiva test than go have surgery. I would say, well, you can do that, but we don't necessarily really know what those answers mean. If it's positive, then I'd say, okay, that pretty much correlates with what you think of as your endometriosis. But if it's negative, does that mean you don't have endometriosis on the inside? And if you have a pain syndrome, if it was pain that drove you to the quest to make this endometriosis diagnosis, I would say in many cases there, you're probably better off with the surgery, because with that surgery, you can correct some of that endometriosis and really live a better life. As opposed to the fertility venue, where you're doing it because we're trying to shut it off long enough so that we can get that embryo in there, get it to stick. Because then once you're pregnant, that baby, you're going to be suppressed really for the next year or so, certainly at least 9-10 months that you're pregnant. And then ultimately, you have a baby, and then maybe you breastfeed for a while. And so that is all going to have a suppressive effect on endometriosis. And it's really probably one of the best treatments there is for endometriosis: get yourself pregnant. So, but we go looking for it when it's causing that kind of problem with pregnancy. Now, it used to be that you would, that we would always, that having a laparoscopy was a part of the workup. It was part of the evaluation that everybody got when they were seeing a fertility specialist. And then what we realized is that, well, you're doing a lot more surgery than is really necessary. It's not improving the pregnancy outcomes. So we moved away from that. I'm not a fan of the surgery for fertility purposes, but certainly if there's pain, then it is a great thing to be able to treat that. It really does make meaningful differences in your life. So let's see, Dunklin Donuts. I like it. Thank you. It just took me a minute there. I'm still learning how to read. But Indipino asks, so why would a normal embryo fail after suppression? And that's a great question because, and the answer is it's probably an embryo issue. So even with a chromosomally normal embryo, which is the best that we can do in IVF, right? That's the best odds we can get, is that euploid chromosomally normal embryo. 65% probability for a good quality embryo. That's what we quote to you. 65% is not 100%. So what that tells us is that the most common reason that an embryo doesn't implant, which is going to be a genetic issue in that embryo, the most common reason has been taken off the table. Same thing holds true with the most common reason that folks miscarry is because of chromosomal issues with the pregnancy. So if we can take that off the table, we can decrease your risk for miscarriage. But the problem is it's not the only reason that an embryo might fail. So imagine inside that embryo, there are literally millions of little biochemical equations happening every single moment. And when they happen, something happens downstream from that. That little chemical equation causes something to happen in the body, some act of metabolism. Well, if something goes wrong with one of those little chemical equations, it can cause a cascade of things that lead to that embryo no longer being able to survive. So when we know that the chromosomes are normal, well, that is the most common reason that embryos don't work, but sadly, it's not the only reason. So why might an embryo fail after suppression? It was because of the embryo, not because of the mom. And that is truly what the science tells us. But it gets hard to accept that, doesn't it? It makes you think, gosh, there's something about me that's keeping me from getting pregnant. Why am I not getting pregnant? We start to ask questions, We start to ask questions about, well, was this because of, some choices I made earlier in my life? Is this God's way of getting back at me for mistakes that I've made? Is this karma coming back to haunt me? Is this because I made fun of a pregnant person once? No, that gives you a sty in your eye, actually. If you didn't know that, that is the folklore. If you're not nice to a pregnant person, you get a sty. All those things are really just a function of our brains trying to justify their own existence by talking to us about things, creating scares that really don't need to be there. I've mentioned this before here too. We are hardwired to deal with that kind of anxiety. It goes back to our days as cavemen. We were not sniffing the flowers in the field. We were constantly monitoring for danger. The saber-toothed tiger was going to jump out from the tree line and eat us. The pterodactyl was going to swoop down and steal our baby. Something was going to happen to it. The dinosaur, the T-Rex was going to pick us up and eat us. These were real threats. The world was a very, very, very dangerous place, And so the brain was hardwired to monitor for that kind of danger. Well, we don't have those kinds of dangers anymore. Well, you know what? If you drive in Miami, well, maybe you do, but in certain other places, the world can still be definitely a dangerous place, but we don't have to worry so much about the sky falling on our heads like we did in caveman days. But the brain is still trying to justify its existence. The brain is still trying to warn us off, to highlight danger, just to make sure that we're prepared. But it doesn't need to. A lot of that is noise. It catastrophizes greater than 99% of the things that our brains fear never come to fruition. And that is really an important thing to remember. Because there will be times that you're going to be racked by anxiety, worrying about perseverating on something bad is going to happen to you, or this is a result of something that you did in the past. And that is just noise. It ain't real. So, Indipino, I hope you know that, and that there will be better fortunes ahead for you and your family. You did the right thing by testing. Now we just got to get that pregnancy to stick. And I really do think that it will. We have Heavenly Joy here this evening, as well as, the wonderful and talented Donna Spicer. Hello, Donna. Nice to see you this evening, wherever it is that you live now. Somewhere in Florida, I think. But great to see you. And Kelly Lee is here tonight on the Facebook side. Thank you for being here, Kelly. Thank you very, very much. Oh, gosh, a bunch of other people joined over here on the New Life side. Zeneda is here. See, now that's a Z name that I can pronounce. That's Zenny in South Florida, who is also a ray of sunshine. And let's see, Deb, looks like Deb is here, who says, miss you, Deb. Deb Avila Jones. Oh, hi. It's great to see you as well. Yes, and Shada says, going through stuff, you're not alone. Hello, Pensacola Wellness and Figi. And yes, I am in a different spot. I changed my location here because I was just trying to change it up and see how it felt. I'm not in front of the brick wall, but I beat my head against the brick wall, if that's of any consolation. Deb says, from my favorite police officer. Yes, indeed. It is so nice to see you. And thank you for not giving me a ticket and for driving carefully. Right? You need to drive carefully. Melinda is here. Michelle is here. And it looks like Tori is here. And there was a question back over here from Shada. Shada says, when should that post-op ultrasound be done? Checking for inflammation 2 to 3 weeks after surgery or right before starting the cycle? No, not until you're ready to start the cycle. Because if you go and you look inside now, it may look like a mess. You just had a big surgery. All that needs to heal. Those peritoneal surfaces need to kind of regrow. Really think of it as the lining of your abdomen has to redevelop. So no, I would just say kind of when it's time to do your sort of baseline for your next FET, that's a reasonable time. And I know you, and I know what you're going to do. You're going to say, well, I want an ultrasound tomorrow because I just want to make sure that I get a jump on things in case something is going wrong. And I will tell you, Shada, don't do that. Do you hear me? Is Mustafa there? Make sure he hears me. Don't let her do that. That is not going to help you. That is only going to cause you even more grief and anxiety. It is not something that you want to look at or need to look at right now. It just needs time to heal. 3 months when you're ready to do your transfer. That's when you want to look at it. All right? Don't make me speak to you in that tone of voice again. All right. Heavenly Joy says, what causes frequent FET cancellations? So that's a good question. And a cancellation of an embryo transfer cycle can happen for any number of reasons. One of the more common reasons is that, well, if the lining of the uterus simply doesn't grow, if it doesn't get to, we like to see that at least about 7 millimeters. And if we don't get a lining that's 7 millimeters, then it may really not be very hospitable to an embryo. And I say 7 millimeters by the time you are starting progesterone. So normally, and you say a homogeneous endometrium. So what happens is that the uterine lining starts out by looking what we call trilaminar. A trilaminar, or 3 layers, which is the top layer, the bottom layer, and the interface between, right? That's what we call trilaminar. That's what it's supposed to look like when it is at its peak, when it's ready for you to start progesterone. As you're on progesterone, it will start to compact, so it will get thinner, and it will become, it will change its appearance and start to, you'll lose that trilaminar appearance often and become kind of, I sort of call it cloudier looking. That would not be a reason. The way it looks morphologically by ultrasound is not something that would cause me to cancel a transfer. But if the lining doesn't get thick enough, that is something that will. Another thing that will cause people to cancel in a medicated cycle, that is that you ovulate anyway. So when we're giving you all these medications in a medicated embryo transfer cycle, we are suppressing your ovaries' ability to make an egg, because when you make your own egg, you make your own progesterone. And that progesterone is the most important part of the timing of when you get your embryo transfer. Technically speaking, 120 hours of progesterone is what we are looking for. And so if you ovulate on your own, well, you just spoiled the soup, because you started making progesterone maybe even before your endometrium was ready. And so that will change things. If your progesterone level starts to go up, usually if it's greater than a 1.5, then that means the soup has been spoiled, and that the lining is no longer hospitable. That progesterone level is kind of what we consider to be your implantation window. And as the progesterone level gets higher and higher, that window gets narrower and narrower. So there were some times where I used to work that folks would be wanting to do a fresh embryo transfer, but because of their stimulations, their progesterone levels got too high. And in that scenario, we would say, we don't want you to do a transfer because the level is too high. It's not going to work. And they would say, well, I'm doing it anyway because I want that. So, that's a choice that you make. But those are really the two most common reasons. You ovulate, or your progesterone rises, or your lining didn't get thick enough. The two most common reasons that people get canceled for FET. Folks, I got to tell you, this fertility thing, it's not the book of your life. It really is just a chapter. And what are we trying to do? We are trying to rewrite that chapter here together. Every step forward with love, every step forward with kindness. I implore you to be kind to a stranger. Do something to make a difference in this world. Let's leave it a better place than we found it. Make people happy. Do what you can to just brighten someone's day, because that little thing can make a huge difference in the way our world turns. Every step forward with hope, knowing that tomorrow is a new day full of all new adventures. So until next week, from Pensacola, I'm Dr. Randy Fink. Thanks so much for being here, and good night.